Welcome to today's explainer. We're stepping way outside the sterile, temperature-controlled comfort zone of your typical modern hospital. Instead, we're diving headfirst into the incredibly gritty, high-stakes reality of austere medicine. I want you to imagine a scenario. Say a mass casualty incident, a remote wilderness trip gone totally wrong, or a massive natural disaster. Suddenly, that entire safety net of immediate, high-tech medical care is just completely stripped away. So how do we actually keep people alive when the system we all rely on simply isn't there? Well, that is exactly what we're going to unpack today. To really wrap our heads around the power of field medicine, we kind of have to look at the military. Back in 2002, the US military rolled out something called Tactical Combat Casualty Care, or TCC. This was an absolute game changer. It completely shifted the paradigm to treating the wounded right there on the battlefield. And when you look at the results, they're literally staggering. Implementing TCC dropped combat casualties from extremity exsanguination, which is just a medical way of saying bleeding to death from an arm or leg injury, by a massive 67%. That number represents thousands of lives saved just by bringing those critical interventions right to the point of injury. Okay, let's dive into this. Because sure, the military has highly trained medics carrying specialized gear. But what happens to the rest of us? What happens to civilian immediate responders, bystanders, or even off-duty medical pros when a crisis hits and standard hospital resources or even just a basic first aid kit are absolutely nowhere to be found? How do we adapt to that?
Section 1. Stopping life-threatening hemorrhage.
The moment an emergency happens, a ticking clock starts. And massive bleeding, that is the single most immediate threat to life. Now, if you've got a severe limb injury, the gold standard is a commercial tourniquet, or a CTQ. These are those meticulously engineered devices like the Combat Application Tourniquet. But let's be real, the average bystander isn't carrying one of those to the grocery store, right? And that necessity leads to improvised tourniquets, or ITQs. These are devices essentially cobbled together on the fly by bystanders using whatever everyday objects they can find at a trauma scene. Things like belts, torn shirts, or backpack straps. When researchers actually studied these improvised tourniquets, they found that one specific setup performed the most consistently. It's called the band and windlass design, and it requires some serious MacGyver-like ingenuity. Basically, you wrap a piece of cloth around the limb, incorporate a makeshift dowel, which could literally be a sturdy branch, a tool clamp, or even a pair of chopsticks, and then you twist that dowel repeatedly to apply occlusive pressure. You basically have to crank it until the arterial blood flow is completely shut off. But here's where the research gives us a massive reality check. You'd think this is a great skill for everyone to learn, right? Well, despite performing decently in a few simulated experiments, a comprehensive review of the literature came to a pretty surprising conclusion. Experts explicitly state that the use of and training in improvised tourniquets by civilian immediate responders is actually not recommended. Why? Because the effectiveness is just way too unpredictable. An improperly applied improvised tourniquet can actually trap blood in the limb, increasing bleeding, or it can cause severe permanent tissue damage. For the untrained civilian caught without the right gear, holding intense, sustained direct pressure with your hands is a vastly safer and totally viable alternative.
Section 2. The sterile glove debate.
So we're going to challenge that pristine TV hospital idea that sterile gloves are an absolute, non-negotiable necessity for every single procedure. To do this, researchers don't use a standard superiority trial because, let's face it, nobody thinks non-sterile gloves from a box are magically better at preventing infections than individually wrapped sterile ones. Instead, they use something called a non-inferiority trial. This study design asks, are non-sterile gloves not much worse? Researchers define an acceptable margin of risk up front. So the crucial point is, why would we ever accept a slightly worse option? Simple. Non-sterile gloves are vastly cheaper, they create significantly less packaging waste, and in austere or resource-strapped environments, they might literally be your only option. A major randomized control trial in the Emergency Medicine Journal tackled this exact question by looking at patients getting traumatic wounds sutured. The researchers set their acceptable, not much worse margin at 2%. To set up the study, they estimated a baseline infection rate of 3.5%. Well, actually, scratch that. They completely misjudged it. When they looked at the real data, the actual baseline wound infection prevalence was almost double, sitting at 6.8%. And on top of that miscalculation, the trial had to be stopped early because a service change at the hospital drastically tanked their patient recruitment. But, and this is the cool part, because that baseline infection rate was so much higher than expected, the data they did manage to collect was actually robust enough to give us a solid answer. And here is that answer. The true difference in infection rates between using sterile versus non-sterile gloves fell within a 95% confidence interval of -3.7% to 1.5%. Because that absolute upper bound of excess harm, that 1.5%, was sitting well below their predefined acceptable margin of 2%, non-sterile gloves officially proved to be non-inferior. For emergency docs, especially those out in expedition settings or conflict zones, this is huge. It proves non-sterile gloves are a completely viable option. The worst-case scenario is a minuscule added risk that you can easily treat with some basic oral antibiotics. Section 3. Prolonged field care realities. Okay, so we've stopped the massive bleeding and we've treated the wounds. But what happens when the helicopter just isn't coming? What happens when evacuating to a hospital is completely impossible and you've got a critically injured patient who has to be stabilized in the dirt for days on end? The military, as you might guess, has a ton of experience with this, and they've codified it in the Joint Trauma System Clinical Practice Guideline for Nursing Intervention in Prolonged Field Care. This document is fascinating. It's essentially a survival playbook designed to give medical professionals evidence-based guidance for nursing interventions to stave off fatal complications when higher-level care is just totally out of the picture. Just take a look at the incredibly granular detail required in this prolonged field care flow sheet and 12-hour care plan, and this brilliantly illustrates exactly what it takes to keep someone alive in those harsh conditions. You have to remember, for a severely injured patient, basic activities of daily living completely disappear. They can't move, they can't drink, they can't even cough on their own. Keeping them alive requires an intense, obsessive level of tracking. Responders have to monitor every single drop of fluid going in and coming out, heart rate, blood pressure, airway status, and medication dosages. And they're doing this literally hour by hour, day after day, all without the fancy automated machines a hospital normally provides. Section 4. The minimum, better, best framework. When you're out there without optimal hospital gear, you desperately need a mental model for evaluating and deploying whatever alternative emergency interventions you can scrounge up. Let's look at airway management as a perfect example of this minimum, better, best framework. If a patient cannot clear their own airway, they are going to choke, period. The best capability here is a closed inline suction machine, your standard high-tech hospital gear. The better option is an open suction tube. But the minimum? A resourceful medical professional can improvise life-saving airway suction using literally nothing more than a 25-centimeter piece of IV tubing connected to a 60-milliliter syringe. It is incredibly simple, it is entirely manual, and it absolutely saves lives when the best option is miles away. Now, what's really interesting about this slide is that it shows us not all life-saving interventions even require equipment. Some just require pure, repetitive discipline. If a patient is immobile, fluid starts to build up in their lungs, which can quickly lead to a fatal complication like atelectasis or pneumonia. The osteomedicine solution to this? The turn, cough, deep breathe routine. You basically instruct the conscious patient to breathe in deeply, hold it for a count of 3 to 5, exhale slowly through pursed lips, and then you have them repeat this 10 times every single hour. It is such an unglamorous, repetitive, simple nursing exercise, but it is the exact intervention that keeps those lungs clear and keeps the patient breathing. But what if the patient is unconscious? Now they are at a massive risk for deep vein thrombosis, or DVT, which are deadly blood clots that form just from immobility. In a modern hospital, you just strap on mechanical compression devices that automatically squeeze the legs. But in a prolonged field care scenario, the medic literally becomes the machine. DVT prevention in the field requires strict, hands-on physical interventions every 2 hours. You have to perform ankle plantar flexion and dorsiflexion, physically bending their foot back and forth. Then you manually massage the lower extremities, applying consistent deep pressure in an upward motion through the thigh, alternating legs 5 times. You are essentially physically simulating the blood flow of walking for them. When we pull all of this together, from stopping bleeding to improvising airway suction and performing those manual therapies, we arrive at this fundamental truth of austere medicine. And it's perfectly summarized by this quote from the Wilderness Medical Society. Wounds should be treated using a clean field, including gloves and instruments. Sterility is not necessary. Out there in austere environments, perfection is the absolute enemy of survival. Stepping up and doing something imperfectly, but safely and immediately, almost always outweighs the fatal risk of just sitting around waiting for perfect hospital conditions. Throughout this explainer, we've seen how the experts break down incredibly complex care into raw, improvisational mechanics. It completely strips away that illusion that saving lives always requires a multi-million-dollar facility. What it really requires is knowledge, sharp observation, and an absolute willingness to adapt to the reality in front of you. So I'm going to leave you with this provocative thought. If the safety net vanished and the worst happened tomorrow, are you prepared to improvise to save a life? Thanks so much for joining me on this explainer, and I'll catch you on the next one.